Welcome everyone to the second SAGE Assembly, virtual SAGE Assembly. I'm really excited to have you here today along with my discussants, Kayte, Spector-Bagdady, and Jen Wagner. We're going to be discussing research and public health emergencies today. If you have questions, please don't hesitate to reach out. You have the chat feature open and available to you. And at the end of this short presentation, then we're going to have a lot of discussion. So you'll be able to submit questions if you'd like to for our discussants to mull over. So let's get started. First, of course, we need to remind everyone of the SAGE Bionetworks Code of Conduct. Our Code of Conduct is really essential to all of the work that we do at SAGE and really guides our interactions with our immediate colleagues and also with those that we collaborate with, like you all today. So thank you all for attending. We expect that you will show respect and attempt collaboration and refrain, obviously, from demeaning, discriminatory, or harassing behavior or speech. We really, more than ever, need empathy and kindness when interacting with others. A few disclosures before we get started. The seed of this webinar came from a number of different sources, including direct conversation, email, Twitter conversations, and has since been reviewed, informed by review of academic, popular, and emerging literature. You can imagine right now in the middle of this public health emergency, there's a lot of new stuff coming out every day. And then, of course, lots more conversation, direct conversation and Twitter conversation. Professor Spector also wrote a piece in USA Today about the importance of research during the pandemic, and that's informed this presentation. The views that we're presenting today, each of the discussants and myself, are our personal views and do not constitute legal or ethical advice and should not be used to justify decision making. So a little bit of background about Jen and Kayte. We're really thrilled to have them. Kayte is the Associate Director of Bioethics Research and Assistant Professor at the Center for Translational Bioethics and Healthcare Policy at Geisinger. Her research is really broad-based and wide-ranging and is informed by her expertise in anthropology, genetics, law, and bioethics. Kayte, meanwhile, comes to us from Michigan. She is a lawyer and bioethicist and chief of the Research Ethics Service in the Center for Bioethics and Social Sciences in Medicine at the University of Michigan Medical School. Her research is also very wide-ranging, and her recent work has been focusing on secondary use of data and samples for additional analyses. So our plan for today is for me to give a short presentation to get us all onto the same page, and then for us to have questions and discussions with Jen and Kayte. So let's get to it. So in case you haven't noticed, we are undeniably in the midst of a pandemic. We have 184 countries that have at least one COVID case, more than 1.5 million confirmed cases worldwide, more than 400,000 in the United States. We have more than 90,000 people who have passed away, more than 4,500 of those in New York City alone. And this morning, the mayor of New York City said that there's probably an additional 100 to 200 deaths per day in New York City that are COVID related, that haven't been being logged. So it is a massive, massive problem. Although COVID seemed like an equal opportunity virus at first, we're now seeing differences in who's being impacted by COVID. As in 2009, when the H1N1 flu killed American Indians and Alaska Natives at 4 times the rate of all other racial groups in the United States, we're now seeing Black Americans disproportionately dying. For example, in Milwaukee County, where Blacks constitute 26% of the population, they constitute 81% of the COVID-related deaths. In Louisiana, they're 33% of the population and 70% of the deaths. In Chicago, 30% of the population and 72% of the deaths from COVID. And in New York City, we see both Black and Latino members of that community dying at 2 times the rate of whites. So we have a very large problem on our hands. And additionally, we're starting to see people who have been traditionally disenfranchised being more severely impacted by this disease. This is really a call to arms. So as in past pandemics, and there have been a lot of them even in this century, SARS in 2003, H1N1 in 2009, MERS in 2012, Ebola in 2014, Zika in 2016, and now the COVID pandemic. It's really one of the key features of pandemics is all of the unknowns. So who has it? Who has had it? Once you've had it, can you get it again? Why is it terrible for some people, not so terrible for others? How long has it been circulating in humans? And this is this call to arms between the questions of social justice and then all of these unknowns. Like, this is what researchers were built to do. Like, this is our shining moment, right? This is literally what we've trained for decades and decades to do, is to answer these questions using scientific processes to provide reliable information so that people can make good decisions and they can not die of diseases. So we're at this critical crossroads for research. Also, this pandemic is a little different. Although we've had a whole slew of pandemics in the past century, as I was just outlining, right now we have entered into this era of big data, and we have massive research banks filled with data and biosamples. And these massive databases of data and biosamples have some unique features which allow them to cross-communicate with one another to create even larger data repositories, which allows for greater solving. We also have oodles of computing power available to us. And in many cases, we have broad consent, meaning that the terms under which the data and samples were collected from research participants allow specifically for secondary research, so for the reuse of that data for other research purposes. So we have the ethical mandate for this, we've got all sorts of research questions, and we have these massive data banks to be able to answer our questions. So we're really poised in this ideal position to be able to solve for COVID, or at least we should be, right? So here's a case example. The Seattle flu study began collecting nasal swab samples back in 2012, or I'm sorry, in 2018, to track the spread of influenza around the greater Seattle area. Excellent idea. So in early February, the Seattle flu study proposed using the samples that they had collected to track COVID-19, and they proposed this to state and federal officials. They said, look, we've got all of these samples. These samples could tell us about who has COVID or who has had COVID within our community. We have samples going back months and months. Why don't we use them and find out about the spread of this disease in our community, which seems like such a good idea. The federal and state officials said no. They said, absolutely not, you cannot do this. This was a shock. And actually the New York Times wrote an article on this at the beginning of March, and everyone was outraged. They were like, well, this is ridiculous. These researchers have this data. They actually had consent from participants to use the data for exploring germs, which maybe could have included COVID. Why are these federal and state officials saying no? So the officials argued that the Seattle flu study didn't have the explicit consent of participants to test the sample for COVID-19 or to return samples to them. Also, that the Seattle flu study at the time was not certified to provide COVID-19 results, which has two dimensions to it, right? The Seattle flu study was using research laboratories rather than clinical laboratories or CLIA certified laboratories to do their flu testing. And the Seattle flu study itself at the time didn't have a coronavirus test that had been approved by the FDA. So the Food and Drug Administration is responsible for making sure that the medical tests that are produced in the United States are trustworthy, that their results are accurate and people can use them for medical decision making. And at the time of their proposal, the FDA had not yet allowed for quick and rapid development of coronavirus testing. And so this was the basis on which these officials said no. And there's been lots of back and forth since then. And I encourage you to go, if you're interested, and read up on it, because there are new developments nearly every week at this point. But this case example sort of highlights for us, we're in this big data era. We have a pandemic that we need to do some research on. We need to figure out what's going on. Why can't we use the resources that we have available to us as researchers? So that's really the question for us today. Can we use research repositories in a public health emergency, and should we use them in a public health emergency? And it comes down a little bit to, well, or a large bit, depending on your perspective, to the difference between public health activities and public health research. And this might seem a little bit like inside baseball to you, but it's really an important distinction to understand. So almost 2 decades ago, Nancy Cass, who's a wonderful and amazing bioethicist, described an ethical framework for health practitioners to be able to distinguish between public health activities and public health research. And she said public health research really focuses on the ethical principle of individual autonomy. So individuals being able to make their own decisions about themselves. And that public health activities, by contrast, focus on the ethical value of justice. And so let's get into this a little bit more so that you can see how this plays out, and then how it might relate back to the research that we hope we can do for this pandemic. So what is research? It's important for everybody to understand this. And for those of you at Sage Bionetworks who just completed your ethics training, hopefully you could write this slide yourself. So research is a systematic investigation designed to develop or contribute to generalizable knowledge. So we're not trying to solve any one person's problems. What we're trying to do is come up with principles or knowledge that can be applied broadly to large groups of people. Human subjects research is when that research involves people that you gather samples from or data from through direct interaction or intervention, or when you use private information from that person. So that could be information about their age or where they live or their name, those sorts of things. Public health research is, unsurprisingly, research that focuses on public health, and an IRB, which is an ethical review board, actually determines if it's also human subjects research. And so if you're a public health researcher, you might propose a research project, and then the ethics board would help you understand if it's also human subjects research. And it matters if it's human subjects research because there are regulations that govern human subjects research. The main one in the United States is the Common Rule. And the Common Rule lays out researchers' responsibilities in their conduct of human subjects research, including the mandate for informed consent, what belongs in that informed consent, and also the role of the institutional review board, the ethics board, in the review of that research. The Common Rule was literally born out of the misconduct of public health research in the past. So this picture is of the Tuskegee syphilis study, which happened here in the United States, which was one of the many unfortunate examples that we have in US history of misguided research that directly harmed participants and also eroded community trust in science and in the research process itself. So these regulations are there for a reason. We've done things badly in the past, and we developed these regulations to help us not make those same mistakes in the future. The Food and Drug Administration also has oversight responsibilities when it comes to working with humans in research. Like I was highlighting with the Seattle flu study, the Food and Drug Administration ensures that we have safe and effective testing, for example, for different sorts of medical conditions and diseases. So these are key regulatory responsibilities that we have put in place to make sure that when we are interacting with human beings to do research, we do it well and we do it safely. One of the challenges, though, is that not all research is regulated. So the common rule applies actually very specifically to federally funded research. So if you get money from the National Institutes of Health or other branch of the government in order to do your research, then you have to follow the common rule. FDA oversight is actually very, very specific, very clearly delineated in the regulations. And then another point is that arguably most data right now is in the hands of private companies. So Google, Fitbit, Facebook, you can imagine all of the different databases that exist, which have oodles and oodles of data about people and their patterns of movement and their patterns of commerce that could be used during a pandemic like ours right now. And this private data does not fall under any of the regulations, generally speaking, because it's outside of what we considered research when the research regulations were first being developed. So we've just talked about public health research and research generally. What about public health activities? So public health activities are intended to prevent a disease or injury and improve health. And it's designed to specifically benefit the people in the activity. So you can think of a smoking cessation program in a high school. So you're trying to get the high schoolers who smoke to stop smoking. This is a public health activity. We're not trying to necessarily do research on them, although we might develop generalizable knowledge in the course of our work. So we might learn about what works with teenagers when we talk about smoking cessation. Many of the same techniques, data, and analysis approaches are used for public health activities as are used for public health research. And this can make it really confusing for people. Public health activities also fall under different regulatory conditions. So public health activities are specifically carved out of the common rule. So the common rule specifically says it does not apply to public health activities, including those that use biospecimens and information from, quote, a variety of sources, which might include research. There's a lot of scholarly support that the practice of public health is itself not research. So if you're doing public health, you're not de facto doing public health research. And another complicating factor, uniquely in the United States, most public health activities are authorized by state and not federal statute. And I think that this is actually a very interesting point. So the United States obviously grew out of our colonies. When the colonies were first founded, each colony was responsible for quarantine and other public health functions. And so when the US Constitution was written, the US Constitution did not include in federal powers public health activities because they were already being completed. Those activities, those responsibilities were already the responsibility of the colonies and then the states under the federal as we came together as a nation. So it's very interesting, but the United States doesn't have a central federal public health authority, which when you think about with this pandemic and the stay-at-home orders, many nations have been giving stay-at-home orders, for example, in Italy or in France or in Spain, but the United States doesn't have that same sort of federally organized public health response. So this leads us to the problem. So who gets to define a public health emergency? Some researchers, and we are certainly seeing evidence of this now, may call their research public health activities to get around the research regulations. So we at SAGE have seen numerous examples of people saying, oh, well, we don't have to go in front of an IRB because this is a public health activity, it's not a research activity. And then there are very few stops on public health activities, especially during a public health emergency. And here you can see a few of the headlines that have come out in the past day about the trade-off between individual liberty and privacy and the public health, and then this idea of a national surveillance system and the use of the Patriot Act. So this leads us to the point where I'd like to open up for conversation. So let me stop sharing my screen and we can start just talking. So I want to also just take a moment to highlight that the Senate Commerce Committee is actually meeting right now, today, to examine privacy issues related to, quote, recent uses of aggregate and anonymized consumer data to identify potential hotspots of coronavirus transmission, which really leads into my first question for Kayte and for Jen. Do you think that the distinction between public health research and public health activities is still meaningful in the big data era? And why or why not? Jen, do you want to start, or Kayte?
Sure, I can start and then pass the torch to Kayte. I think we'll have maybe slightly different perspectives on it, just given what our day-to-day responsibilities tend to be. I think that the distinction is useful, but it's not perfect, right? I think it's complicated. It's a gray area that becomes really problematic to operationalize in the context of a public health emergency, right? If we're not in a public health emergency, it's less problematic. But in the current circumstances, I think, just as you were mentioning, you were seeing from SAGE, the concern is that people will try to get around the mandatory research oversight that might apply by calling something a public health response or a public health activity, when in actuality their motivations are different. It is for generalizable knowledge and what they're trying to learn. So I think that can be somewhat problematic, but I think it also speaks to this confusion, speaks to this other issue, whereas it's not that public health activities are completely free from oversight or completely free from any kind of ethical obligations, right? So the CDC has a public health ethics committee that was founded in 2005. The World Health Organization has both a research ethics committee that reviews proposals, as well as a public health activities consultation service to deal with some of the ethical challenges that are there. So, you mentioned Nancy Cass's paper back in 2001, I believe, that kind of tried to set out at least an analytical framework for how do you evaluate or assess the potential risks and benefits of a public health activity in a similar way that we already do using the common rule for research and weighing the benefits and risks and the like. So I think the distinction is useful. I think in the case of a public health activity, you do want it to be somewhat nimble. And if you're responding to something where time is of the essence, having mandated processes can slow things down. Yeah. Right. So it's trying to find that balance, but I think it's somewhat problematic, and I'll leave time for Kayte to talk about this too, because for me, I think it is similar to the conversations that we hear learning healthcare system experts talk about, with this breakdown, the dichotomy that's pretty much false for the practice of medicine, right, and research in a healthcare setting. So I don't know if Kayte wants to pick it up there or say something different about your perspective about that distinction.
Sure. So I will agree with everything that you said. So we'll talk about a slightly different but related concept. And so I guess I must admit that the thing that worries me more than the distinction between public health research and public health activities is who is governed by these laws that make the distinction, right? So as you pointed out at the beginning of your talk, actually the majority of our data currently, our health and health related data, are privately held by entities that don't necessarily have to worry whether it's a public health activity or public health research, because they're not federally funded, they're not submitting in support of a new drug or device, and so really they don't have to follow the rules. And I think that one of the things that the committee today is focusing on the Hill, which I find concerning as well, is the proliferation of both health proxy data, right? So your health data are obviously protected by HIPAA if they are definitively identified health data, and also are held by covered entities, so by hospitals or doctors. But there are all these data that have a lot of information in them about our health that are not technically health data and are not covered by covered entities, right? So if I wake up and my iPhone geolocation data says that I woke up, I went from my house to work, and then at the end of the day went back again, so that's identifiable to me. And then during the day I visited my psychiatrist, I went to yoga, and then I spent 5 hours at a bar. Right? Those are data that are all relevant to my health, but are not actually protected health data. And so what's going to happen is that entities, including the government, that are interested in tracking these data, they don't need to come to academic medical institutions or to hospitals who are collecting these data through our normal mechanisms that are highly regulated. They can go to Google or to, people who are owning the geolocation data. And we've all seen, it's very cool. The Times has done some really cool stuff with people spreading out either from that street fair in China or from, spring break in Florida, and all of the places that they're spreading to. But what seems acceptable to us during a public health emergency and saying, oh, great, that's really interesting, I'm really glad we can do that now, then stays, right? So if the government adopts these urgent violations of privacy, which seem justified given the fact that people are really dying now, what shuts them off after? So I'll stop there.
Right. And this is really why I was posing this question, is that we have just been slingshotted right into this new era. And I think that COVID is really highlighting for us the fact that these data, which are critical to tracking the pandemic's spread, are not traditional health data and can be readily obtained and used in so many different ways. And if we were to marry them with actual health data, we might be able to do some very, very interesting solving. And so we have this gap between the lived reality of our data systems and the regulations that exist to guide our use of them, which is, I think, a really an interesting side effect of this pandemic. But as you point out, Kayte, what we give up now, and we saw this, I mean, the references to the Patriot Act are well taken. We saw this after 9/11, where we gave up all kinds of individual rights in favor of terrorism countermeasures or terrorism surveillance.
Meg, one of the questions that I think we might want to talk about a little bit is we've been focusing on data right now, not thinking about other things, right? So to go back to your initial example that started the conversation, the Seattle flu study, it wasn't necessarily using existing data, it was using samples, right? Which is to generate data, right? And what are you using those data for? Is it to alert people that, hey, you might have immunity or you might have an infection, who knows, but something related to a public health response versus we're trying to understand this virus, right? Or we're trying to do something that is really scientific research. I think that's where one of the questions does come into play. So thinking about research resources broadly speaking, I think raises some other dynamics that are worth exploring.
Yeah, and this is actually one of the questions that I have for you both is about research infrastructure. So the use of the research infrastructure, which includes IRBs, which includes the databases and the samples, which includes the connection to participants. What are the concerns, or do you not have any concerns with reusing that entire infrastructure for a public health activity? I mean, from my perspective, I think about the funding of research and the lack of funding in public health. And are we just trying to shift responsibilities so that we don't have to put more money into the system to make an effective public health response, a robust public health response body? Kate, what are your thoughts there?
Yeah, so yes, I agree that's a concern. I will add to that concern as opposed to actually solving that concern for you. One thing that I have been worried about lately is all of the different COVID-related intervention buckets that are simultaneously occurring in our health systems, right? So I think, so add to it, please. But so first of all, if a patient enters a hospital right now, they could get standard of care clinical intervention, which is, we don't really know what the best practice is, but there was a recent practice guideline that came in, but whatever that standard of care is defined as. They could get innovative care, which is also under clinical care, which is something outside of the standard practice guideline for COVID, but people think might work, an individual doctor thinks might work for an individual patient. We've got expanded access protocols where people are getting access to drugs or devices that are currently under investigation and which haven't reached the market. We have emergency use authorizations going into FDA, which is again under clinical, it's not research, but practitioners are getting emergency use authorizations to, for example, use different kind of vents or use different kind of vent splitters, which is under clinical. And then under research, we have biospecimen, we have data research, and then we have human research. I mean, there's so much going on right now that systems are set up to deal with on sort of a one-by-one slow basis, and we have weeks to discuss it and committees, and suddenly they're all coming in at the same time, and I think it's really overwhelming the system. So not only is the disease overwhelming the system and overwhelming our resources, but it's also overwhelming our oversight and our governance capacity as well.
Yeah, I think you raise a really, really great point there. And I'm just going to acknowledge one of the questions that we have from one of the attendees, actually, which was related to who gets to decide whether something is an activity or research, and raising the similarities to how this works with the IRB, right? Is it the researcher's determination that this isn't research or this is exempt, for example, or is that the oversight body? When you're in a public health emergency, just as you were saying, Kate, we have scarce resources, right? And you don't want to take away the energies and effort and attention of the oversight bodies with things that they really shouldn't, I won't say they shouldn't care about. They should care about them, but when we're prioritizing where are we placing our efforts, they need to pay attention to the clinical trials. They need to pay attention to the situations where people, could live and die by what is happening or what experimental drug they might have access to, et cetera, thinking about all of these various issues. So I think, placing public health activities outside of that framework, while it doesn't, let them just do whatever they want, I think is a compromise we have to be willing to take in this sort of context.
Right. As of a month ago, I was a secondary research with human specimens and data expert, and we're all public health COVID experts now, right? Like that's all anybody's doing. So
yeah. And Jen, I agree with you and Kate with the points that you're making. And yet I have these concerns. And I think that I think that starting to see the data for the US about the disproportionate impact of COVID-19 on Black Americans and Latino Americans is really highlighting to me social justice concerns which have always existed. You know, I mean, this is not new. We have well documented social justice issues with the U.S. healthcare system. But will this need for speed or our need to move quickly only exacerbate these disparities? Like, how do we pivot this so that we move quickly and solve better for more people? And that's the piece that I am a little bit concerned about. You know, the common rule arose from largely white researchers taking advantage of largely non-white disenfranchised populations. How is now different? What do you see that same concern? And do you have any ideas about ways that we might put guardrails in place or encourage researchers down and public health officials down a more equitable or just path?
So, I mean, it's tough, right? I think that what we're seeing now is just how bad our public health system is, right? How bad social injustices are. You know, we're seeing it with housing, and how even if you're trying to do the right thing with social distancing and quarantining, that's really a privilege for so many people. And so I think, you know, you're having this pandemic raise all of these equity issues, highlight the disparities that are there. And at the same time, we're really ill prepared to deal with this pandemic itself. And so we're going to see that, I think we're going to see that be exacerbated, right? When you're having a really awful, challenging decisions to be made over allocation of scarce resources in a healthcare setting, right? Triage policies.
Yeah, I mean, the disability community has been up in arms around the triage.
And I think that they're right to be upset. I think that we absolutely should be sounding the alarm that there are concerns about the inequities that are here. I think that we are asking too much of triage policies to solve those problems.
Yeah.
Right. I don't think that's the right time. I think we need to ensure that those processes are fair and carefully designed. And I'm grateful to all of my bioethics colleagues and ethics folks out there who are working on those policies for their healthcare systems, because it's not easy. But people are trying to ask the right questions. They're trying to make sure that things are transparent, that the community is engaged in that process, taking into account what principles get highlighted. So I think making sure that the health equity issues are front and center during the conversations is going to be key. I just don't think we're going to see the solution to those problems immediately. I do want to circle back to, you know, your initial question, which was kind of about using research infrastructure, this need for speed, and using research infrastructure and how it maybe lets us be lazy as a society to not invest in public health better. I do have concerns about that. I have concerns that it will set back research. I have concerns that it will set back trust in what people are trying to do with precision health, for example. You know, we started off talking about the Seattle flu study, reusing specimens. I have concerns about the All of Us research program. You know, I haven't been tied into that for some time, but here we have a resource, a cohort of individuals who want to help, right? Want to help improve our understanding of health. Volunteering specimens for various broad research uses. I think research uses are the important part there. They might not have anticipated a public health response use to those specimens and data at the time, but also the ability to contact those individuals, right? I think all of that infrastructure makes it highly attractive at a time like this to say, ooh, we have this resource, let's tap into it. I mean, some would say there's a moral imperative to use every resource that you have to try to solve this because of the high fatality. And I think that if we do that quickly or even quietly, without engaging the people who have provided consent for that process, I think we will risk the sustainability of that entire system. You know, for example, we didn't get into much of this just yet about federalism and public health response and things like that. But, if you have Indigenous Americans who are in that cohort, there are other considerations. It's not just the federal government, the state government, the local government. There are also tribal governing rules that should be taken into account. And there also should be, a consideration about what ramifications are going to be there based on the reporting that is done, right? So if you're contacting individuals for a public health response to say you have antibodies or we think you were previously infected, who do you know? Who were you around? Who else can we talk to? You're doing that in a way where there is some sort of identifiability, right? Not only of that individual, but of people that they know. And that is particularly concerning in the current environment, given immigration. So some scholars have brought up the concern that undocumented immigrants aren't getting tested, aren't getting care that they need because they're worried about the public charge rule that just took effect in February. And so, our governmental statements that this act of seeking care isn't going to be used against you, is that going to be enough to have trust? Is that going to be enough to have them get care? And so I worry about using an existing research infrastructure that was developed with really great intentions to be inclusive, right? To get over some of the hurdles that research has had historically, to engage communities and do this in a way that is going to be equitable to help everyone enjoy the science that comes out of that. I worry that using that at this time could set the entire thing back. Yeah, you've raised a lot of important points there. I mean, we certainly don't know, for example, the ways in which antibody testing or antibody titers might be used to mandate back to work or to prevent people from going back to work. Could a false incentive structure be set up that people will purposefully try to infect themselves so that they can then have antibody titers and be allowed to go back to work and endanger their health or the health of their families or the people around them? I mean, there are a lot of potential implications for the tests that are being developed right now or being used right now that we don't know what the implications are going to be. Kate, what are your thoughts here? We've gone on a bunch of different topics. So
so I'm going to go back to the race line, because I must admit, I'm sick over this right now as an ethicist that's trying to give recommendations on best equitable policies. So Michigan as well just released our race-based data just a couple of days ago. And just to give you some highlights, the state of Michigan, not the university, but the state of Michigan. So the state of Michigan is 14% Black, yet our COVID death rate is 40% Black. And so I think it's important not only to recognize health disparities, right? Because we know that comorbidities exacerbate the effects of COVID, right? So if I live in an urban area with high pollution, I'm more likely to have asthma. If I have asthma, I'm more likely to have aspiration issues if I get COVID. The African American community also has higher rates of diabetes, which for whatever reason, I think it has something to do with your blood processing of oxygen that is lowered in diabetes is also very much COVID affected. So those are the health disparities, but also there's economic disparities, right, too, that are compounded in an infectious disease situation, right? Because communities of color are also more likely to have a job that they have to show up to get paid.
Yeah.
So not only are you more
Mayor de
likely,
Blasio was pointing this out this morning. Yeah,
exactly. So not only are you more likely to get infected, but then if you get infected, you're more likely to get more sick. So here's where the rubber really hits the road on the research ethics of this. So if, so 33% of COVID cases right now in the state of Michigan are amongst African-American patients. If we're rolling out research protocols in our hospitals, African-American patients are going to be overrepresented in public health research than our white patients. As you pointed out, there is a long history of very bad public health research targeted at communities of color in order to benefit white communities. And then also, and I know this isn't a conversation about clinical ethics, it's a conversation about research ethics, but also, the New York Task Force and many of the currently released health rationing schema are based on something called a SOFA score, the Sequential Organ Failure Assessment. If I am more likely to be suffering from comorbidities and I am more sick, I'm also more likely to score poorly on the SOFA assessment. So not only are we randomizing more patients potentially into clinical trials that are African-American as are represented in the patients, but at the point where hospitals get to rationing, they may also be overrepresented in the rationing schema. And so I think this cyclical situation is really bad. And it's not that we invented health disparities, and it's not that we invented economic disparities, but how are we going to write equitable policies that don't compound them without factoring in race?
Yeah, Kate, I think that's a great point because, I said we can't expect the triage policies to fix the problems, which I do think is true. But at the same time, we can't have quote unquote colorblind triage policies. That
because this is not a colorblind disease.
Inequities. Absolutely. Absolutely. I don't think there's an easy way to do that.
Yeah.
Sorry, I feel like you keep asking me questions and I keep just making them worse.
No, I mean, I think that this is really like, this is like our job, right? Our job is to think about these really hard questions. And it's unfortunate that it takes a global pandemic for us to have these issues highlighted to us in such stark terms and to get the attention of the world starting to turn towards them. But it is a real opportunity to engage with them and to engage with these really thorny questions with a much broader audience, arguably an audience who all should be at the table to begin with, right? So I don't feel like I don't feel like you're just piling on. I feel like you're bringing richness to this conversation, and hopefully this is of benefit to the group that's listening today, and will have ripple effects out to the broader community at large. So let me look at my questions here, because I had a bunch of questions for you guys, and we've gone in a bunch of different directions. We've talked about health disparities. We've talked about rationing and triage. We've talked about reuse of or appropriation of the research infrastructure for the purposes of health activities and the potential challenges there and benefits there. We've talked about the big data era and the lack of anonymity. I mean, because at this point, every time somebody says, oh, but we're just using anonymous data, like I just snort, because there is no such thing as anonymous data. And so if you could wave your magic wand from a bioethics or legal perspective, what do you think is the change that would help us move in a more ethical direction or ensure that the research enterprise moves in a more ethical direction as we face this pandemic? Is there anything or any things that stand out to you? And I was, Mark Rothstein was recently commenting, you know, he had like 3 things on his wish list. One was universal health care, right? So that we would help address this social disparities in health. And then there were a few other things on his list. Are there any things that come to your mind when you think about this? Kate, what do you think?
I mean, sure, universal healthcare,
Yeah.
competent federal governance. My wish list is long, but I guess sort of a more unique observation that I will say is, you know, how long have we been debating the breakdown between research and clinical care and the need for a learning health system? Decades, at least, you know, I mean, we've been talking about it for a really long time, and it didn't really get any leverage in the recent revision to the Common Rule. And then suddenly we have a global infectious disease pandemic that we don't know how to treat. And it's like, surprise, everybody's a learning health system, right? Because we have no idea what to do. And so wouldn't it have been nice to have solved some of these structural and administrative issues prior to being forced into a learning health system? And so I guess one thing I hope that we learn in retrospect is the need for this fluidity between research and clinical care that's so critical. And usually, you know, we're asking our cancer patients, we can't help you, we can only help future patients like you. Can't we get beyond that point? Like, can't we get to the point where like we are constantly, iteratively updating our clinical protocol to help future patients, but also hopefully you by the end of your course of care? And that's what we're doing right now. So I really hope that we, you know, and that's what we're doing in like a week and a half. They're like, you know, Kate, write a new learning health system structure. Okay, but you know, I hope that we keep some of those lessons learned, so we keep that for some of our future patients.
Jen?
So I would second that, all of those things, universal healthcare and learning healthcare system. And I'll take it a step further and say we need to get around this silly notion that our health only matters if we're seeking the attention of a medical provider. Health, the things that impact our health are all around us. So it's not like we can deal with health law in this vacuum that doesn't take into account all of these other things. So the social justice issues absolutely need to be given attention. I think in terms of a concrete example that I would have is, you know, when we look at the kind of public health ethics having this focus on justice, not exclusively, but more so than what you typically see in a biomedical ethics space, where autonomy is given a lot of attention. Let's put it that way. It does dominate, for better or for worse. I think that we need to acknowledge respect for persons, and an individual person even should include recognition of that person's right to public health. Which is a different concept, right? So when I was trying to do some just digging in terms of what would it take, what does that look like, I found a wonderful article from last year written by law professor James Hodge and others on the constitutional right to public health. And I think that if we want to think big, we need to think about something like that, about finding ways to have that be widely recognized and to have it actually help us. You know, if we're going to blow up the system in terms of our federal governance structure, fine, blow it up, but build something better, build something that's actually going to help us with the challenges that we're facing in modern society, with big data, with global interactions. That's
so rather than transitioning from our, you know, state-based Byzantine public health system to a unified national public health system, to think a little bit more outside of the box. And if we're going to have a federal agency that takes responsibility for public health, that it's a much broader definition of public health, and it includes a much broader definition of health and a much broader base of data than maybe have been traditionally considered the domain of a national public health system.
Right, like you said before, Meg, gee, wouldn't it be so nice if there was an entity in charge of coordinating public health responses across the states?
Yeah, so
let's work on that.
Let's work on that. Yeah, so that the governors didn't have to bid against one another for masks for their states. Yeah, if only there was some sort of, I don't know, uniting document that we could turn to for guidance. Yeah. All right, in our last minutes, any final thoughts or comments? Jen, Kate?
I guess, so there was one last thing that you had said during your really good presentation that I wanted to respond to, and it was the comment based on, I think, Nancy Cass's paper, but that like public health research is autonomy focused, whereas public health activities is sort of justice focused in terms of communities. But I will also say that where it gets really quirky is public health research is autonomy based until they enroll. Right. And so there's actually a recent interesting piece about this in JAMA, and is something that I am coming across myself, this inherent tension between having our clinicians really want to help the patient in front of them and being so used to letting this doctor-patient conversation and choice dictate what we do. And it's really hard for individual doctors to say the choices are clinical trials, and then use best practices for randomization into clinical trials that doesn't involve necessarily patient choice between clinical trials, because that's sort of a misnomer, right? And so I think that one of our challenges is this breakdown of the traditional structure of, usually when you go to the hospital, there aren't like 10 clinical trials competing over the same disease function. You don't have a choice between clinical trials. There may be one clinical trial, or there might be none. And I think that that has brought into relief for us the breakdown again between clinical care and research randomization and the generation of generalizable knowledge, I think is one of our big challenges.
Right, right. And in other nations, we see this play out all of the time. For example, in England, people are constantly fighting against the NHS because they're not getting the individual care that they think they deserve. And the NHS is saying, we are a public health entity and we are focused on benefiting the public health. And so there's less focus on individual autonomy and respect for persons, and more focus on this social justice benefit to the community.
Right, it's incredibly un-American not to allow wealthy consumers of health to do whatever, to pick whatever interventions they want.
Yeah. Jen, any final thoughts from you?
Yeah, I mean, I guess I would touch on the privacy aspects, and just kind of recognize public health has always caused this tension with, you know, how far do your private rights extend in this certain context. And I think now more than ever, you know, we've been trying to find a way to grapple with big data using the current kind of siloed approach to data privacy in the United States. And we've been kicking that can down the road for how many decades. And it's really biting us in the butt right now, that you know, we haven't found a framework. We haven't found something that, you know, can get sufficient support to have us make better decisions, not just in times of crisis, but in times of normalcy. And I think, you know, we've seen, you know, some very eloquent writing about the, you know, pre-COVID-19 and post-COVID-19 kind of society. And I think we do need to think about how much we let this particular pandemic dictate what's next. So I would like for us to take a step back and be a little bit more thoughtful about all of the problems that we knew were already there, that we've been trying to grapple with, take this extra complexity and chaos into that mix, and think about responsible data stewardship, right? Think about what does it mean when we're using data in various contexts, and how we prevent those informational harms and consequences that might be down the line. So, you know, lots of hard work ahead, but I think privacy has to be one of those issues that we think about.
Yeah, for sure. Well, Kayte, Jen, thank you both so much for joining me for this conversation today. And thank you to all of our audience members who submitted questions and comments, and to all of you on the line. We so appreciate your attendance, and hopefully this sparks further thinking and further conversation for you as well.
Great.
Thanks again, everyone, for joining. Yeah, thank you. Take care.
Bye.